I'm happy to be going into a more clinical subject, that is management of asthma, exacerbations in children. So I'll start off with a case that we may be familiar with, either your patient as a clinician or your patient as a caregiver. So there is this 3-year-old male presented with history of cough for 2 days, had difficulty in breathing, and was wheezing for the first time. The mother also mentioned that this child had a low-grade fever. When this baby was examined, the temperature was 36.8, had no pallor. The respiratory rate was 48 breaths per minute, and given the age group, that was fast breathing. The child also had chest indrawing, and when the clinician listened to the lungs, the child had wheezes on both sides of the chest. So the clinician gave treatment, gave nebulized salbutamol, 2.5 milligrams in 5 mils of normal saline. Also gave this baby hydrocortisone 100 milligrams 6 hourly for a day. And the baby was also put on ceftriaxone 1 gram once a day for 5 days, and went away with syrup ascoril 5 mils 3 times a day for 5 days. I'll bring back this case to guide our discussion, but such cases are not very unfamiliar in our setting. So going to the subject of asthma, what is asthma? The things that I've highlighted are very important when we are managing patients, right from taking the history, but also the choice of treatment we give. So asthma is a heterogeneous disease, meaning that it presents in several ways, in many different ways. And the key things around asthma that there is chronic airway inflammation. And because of that inflammatory activity going on, these children respond to stimuli which other people don't respond to. So there is airway hyperresponsiveness, and eventually there is airflow limitation. And if you look at that photograph of the lungs I've put there, it is that tree, the bronchial tree, that is affected. That is where the hyperresponsiveness is and the airflow. So when we're managing children with asthma, adults with asthma, let us always remember that we are dealing with the inside of the airways. And so by defining it, it's usually a history of symptoms like wheeze, they have shortness of breath, they usually complain of chest tightness for older children who can complain, and they have cough. But the important thing about these symptoms is that they don't always have to be there all at the same time, but they also vary in intensity, and so does the airflow limitation. But important to note in the context of these exacerbations we are talking about, if they are not managed appropriately, if we don't manage symptoms of asthma appropriately, this airflow limitation, instead of being reversible, eventually it becomes persistent and later on leads to other diseases like COPD in adulthood. So what is an exacerbation? This is an English term. Basically, it means a process of making a problem, a bad situation, or a negative feeling worse. But in the science of asthma, we are looking at an acute increase in the severity of a problem, but in this case, the severity of the asthma. And so the reason we are saying it's an acute increase, remember I've said there is already chronic inflammation going on. So when there is an acute increase, we are saying the inflammation is out of the way, or it has rapidly increased, leading to those symptoms that I've mentioned. So specifically, when you're talking about an exacerbation of asthma, we are talking about a flare-up, and this is either acute or subacute worsening of the symptoms. But it's not only the symptoms, the lung function is also worsening. Usually, if we are able to compare with a patient's user status, you'll find that they have worse lung function. So the important point to note that whereas some children may present with a short illness, for some children, it will be subacute, meaning they may even have a cough for 4 days, they've experienced some symptoms, eventually they land into your hands. So it's not always that dramatic acute response that we commonly see. The other thing to note is that a lot of terminologies are used when we are describing an exacerbation for various reasons. Many times we call it a flare-up, that's what we prefer to use. Exacerbation is good for us scientists, but please do not use this term for patients. It's a tongue twister and they give up on understanding what you're trying to say. Attack, we also commonly use it, but people take it differently. Some people take it as that English word it is, and it's very scary for them. But what we recommend, or we don't recommend at all, is to use episode to describe an exacerbation, because it takes away the thinking that this is an urgent thing to deal with. So right now we are okay using flare-up, exacerbation, attack, but using the word episode is highly discouraged because it doesn't convey the urgency that an exacerbation requires. So just to describe what exactly happens when we say this child has a flare-up, an attack, or an exacerbation. And these things I'm highlighting are going to help us in thinking through what we need to do in order to help this patient. The basic things we need to do. So when the airways react to the stimuli like talked about, like dust, cold, viral infections, and other things, what happens inside the airways is what you see in that picture. On the extreme, I think that would be my left, is the normal airway. It is wide and nice. There is no mucus, so the child is able to breathe properly in and out. So when the airway overreacts, then you see the narrowing, the edema. As you can see, the thickening has increased. And eventually, in severe cases, you actually have bronchospasms. If you look at the outermost bronchi, you see things tight around it. And so you can move from a normal airway to the extreme end where you have bronchospasms. And so as a result of all these processes, you end up narrowing, and this irritation or the acute inflammation leads to the cough. Because there is narrowing, there is difficulty in breathing. Because there is narrowing of the airways, the child cannot take in sufficient amounts of air. So they experience eventually chest tightness because of that airflow limitation. Or they may say that I have chest pain, or they may say that I'm feeling heavy in the chest, or they say I'm feeling like I'm being strangled. They express it in different ways for the older children. But the bottom line is that there is narrowing of those airways, as you can see in those two airways that have been looked at. And eventually, for some people, you may actually be able to hear what we call an audible wheeze. If you put your ear near to the child's mouth when they are breathing in, you'll be able to hear the wheeze. Sometimes it's not possible, especially in smaller children, it's a little bit difficult. But the wheeze is as a result of air passing through the narrow airway, as it were. And so after listing those symptoms, you need to do a physical assessment. When we are talking about the exacerbations, the physical assessment has mainly two goals. Number one, you want to determine the severity. It is extremely important that when you are seeing a child who has an asthma attack, you grade the severity, because as we shall see later, it is the one that is going to guide you in the choice of treatment and how to reassess. The second thing why you need to do a physical assessment, as you manage this child, you need to evaluate response to treatment. There is an algorithm we use from first step to the last step. And so you need to evaluate whether the child is responding optimally or it's suboptimal. And without doing the baseline assessment, it will be difficult to you to understand whether the child is responding. So again, I highly recommend that do a physical assessment, determine the severity, but also use that baseline that you have got to find out if the child is responding to treatment. And so I'll now move to how do we assess the severity. Like I mentioned earlier, it is very important to institute appropriate management. There are basic things you need to assess for very quickly. Make sure you take the respiratory rate and determine if the child has fast breathing or not. Make sure you get the pulse rate, the blood pressure, and look at the general condition of the child, especially the degree of breathlessness. And this one can be assessed by trying to talk to the child if they're able to talk, and find out if they're able to talk at all, they're able to complete sentences, or they want to talk at all. Many times people come when they're having an attack and they're just staring at us. Don't think that children are being naughty. They are reserving all the little oxygen they have to live so they cannot talk. Find out from the parent, is this child able to feed, or are they feeding with difficulty? So do that rapid assessment of the respiratory rate, the pulse rate, the blood pressure, but go ahead to kind of get the degree of breathlessness by assessing the ability to talk and to feed. More assessment you need to do, use of accessory muscles. So you are looking out for chest indrawing, you are looking out for the muscles in the supraclavicular region and the suprasternal region. That usually helps you to understand how distressed the child may be. I know for people who are here, when we are looking at children under 5 years of age, looking at the IMCI guidelines, we largely look at the lower costal margin for chest indrawing. But if you have a suspicion that this child may have an asthma attack, please look beyond the lower chest margin. Look for the supraclavicular region, the suprasternal region to look out for use of accessory muscles. Use the stethoscope to find out if the child has wheeze and how loud it is. Now, if the obstruction is severe, you will not be able to hear any wheeze. And that's why we say that the loudness of the wheeze is inversely proportional to the obstruction. So if you're not hearing any wheeze, it doesn't mean that the child is well. The child may be actually badly off. The same way you will find that when you institute the right treatment, the child's wheeze may instead increase. Doesn't mean that the child is getting worse. It's actually a sign of the problem. Look out, check for air entry. Many times when we listen to the chest, we want to listen for crackles, but to find out how much air is entering through this bronchi by listening for the air entry. Look at the mental status of this child, the level of consciousness, if they're agitated, and this is usually due to the low oxygen saturation that they're having. Check for cyanosis. I know these days pulse oximeters are more readily available. Please make sure that you check the oxygen saturation. That is one of the objective ways of assessing response to treatment. In centers where you have the peak X-ray flow meter, please measure the peak X-ray flow. It's also very important. But if you don't have it, the signs and symptoms that I mentioned above is sufficient to help you move on to manage the child appropriately. So after doing that assessment, you want to classify the severity. Like I mentioned earlier, do a physical examination, 2 goals. Classify the severity, and it will also help you in checking response to treatment. So we have 4 classifications, or 4 categories. A child may either have life-threatening asthma, or a severe asthma exacerbation, moderate or mild. Now, when you're classifying, don't start to look for mild signs. Start with the worst case scenario. So if you're comfortable, if they don't have life-threatening asthma, then you go on to severe. Otherwise, if you start with the lowest grade, and yet the child has the life-threatening asthma, you're wasting time, you're reducing you're increasing the risk of death, you're increasing the risk of complications. So as you go through those signs that I mentioned, try and find out, is this life-threatening asthma? Am I dealing with severe asthma? Is it moderate? And lastly, mild, because your goal is to manage the child as quickly as possible, relieve the obstruction so that you save their lives. And I'll not go into the details of how to classify each one, of how to assess whether it's life-threatening, severe, moderate, or mild, because the signs are quite many, and these slides will be available for us to make reference to. But the emphasis I want to make here is that you have to look at the clinical signs and do some measurements, and you combine these ones to find out if the child has life-threatening. For example, if the child comes in and they're cyanosed, that is already a sign that they have life-threatening asthma. So you don't have to find out whether it is severe, moderate, mild. They already have a sign of life-threatening, and you swing swiftly to help this child. If they're drowsy, if they're confused, if you have a pulse oximeter and that's the first thing you have been able to measure and it's less than 90, please just quickly classify this child as having life-threatening asthma and proceed with the management, as we shall see later. The same thing for severe asthma exacerbations. You will notice as you read during your own free time that the symptoms are not as bad as for the life-threatening. For example, whereas the child with life-threatening asthma will not be able to talk at all, a child with severe asthma will be able probably to talk, but may not be able to complete sentences. They will be agitated. They will be hunched forwards. They are not just noticed sitting forward. You usually want to look at the child's condition. There are always telltale signs if they're in a bad situation, and you should be keen to look at those and quickly swing into action to do a rapid assessment and help the child. I'll not go into the details of each of those clinical signs, but those are the signs that you would use to find out if this child has severe asthma exacerbation. The signs become less severe as we move to a moderate category. For example, this child will be able to talk, but in phrases. They would prefer sitting to lying down. So don't force the child because you want to examine the way we're trained in medical school. If they're having a severe exacerbation, they are struggling to breathe, the most comfortable position for them is to sit. So examine when they are seated. They may not be agitated. They are not using accessory muscles of respiration. And usually their oxygen saturation is within the normal range, but still they are not well, and you need to attend to them. And lastly, the mild classification. These ones are able to talk in sentences, usually not agitated. Sometimes these ones are even very difficult to note because they may even be in your clinic playing around, only until when you take a keen eye to really make these measurements that you'll find out that they're actually having a problem. If you do the respiratory rate, you'll find it may be increased. They usually have a normal pulse rate, but when you listen, you usually find a wheeze. So it's not uncommon to have these young children playing around, but when they are having an asthma attack. And as we shall learn later, exercise is one of the triggers of attacks. So they may actually worsen the attack while in your clinic because you've not noticed that they're actually having an exacerbation. So that's the way we classify asthma severity when children present to us with asthma in an asthma attack. And so with that classification, then it is going to guide you on how to proceed with management. So we've gone through the signs, we've gone through the symptoms, we've been able to classify. So we have the baseline information, we've determined this is how bad this child is, and therefore you move on to decide which treatment you want to give. So I'll now move to treatment. I want to emphasize again that when you're treating a child with an asthma attack, your primary goal is to remove the obstruction. Remember, I said they have two problems. There is an increase in the inflammatory response of the inflammation, which leads to edema, to the reddening, and therefore there is narrowing. So because this is an emergency, you want to save a life, the first thing you should be thinking about, how do I remove the obstruction from this child so that child can breathe well, can get enough oxygen, and they can live. The rest of the things can come later. And the reason why I'm mentioning this is not uncommon for us to receive these children in our settings, and the first thing we are looking for is a cannula to give IV hydrocortisone. Please always remember, if you want to save a life with an asthma attack, do everything possible to remove the obstruction that is as resulting from the attack. And so the cornerstone of management is really to use the inhaled short-acting beta agonists. And these are the ones that relieve the obstruction. And the common one we have on our market is salbutamol in different brands, but at least we know that it's salbutamol that is commonly used. And the preferred route of giving this salbutamol is the inhaled, not the tablets. I repeat, not the tablets. The preferred route is inhaled. And this can be in two ways. You could use a nebulizer, and this nebulizer the nebulization could be oxygen driven or air driven. So if you're in a setting where you have an oxygen cylinder, you have an oxygen concentrator, you have the walled oxygen, and you want to give both the salbutamol, at the same time, the oxygen saturation maybe is 85 in your child, you want to give the oxygen as well as the salbutamol, use the oxygen to drive the salbutamol solution so that the child is being relieved at the same time is receiving the oxygen that they need. If they don't need the oxygen, they are saturating at 95, you can use the air-driven nebulizers that we know about. The other alternative route is the pressurized metered dose inhaler using a spacer. So this is our preferred route of giving medication to children who come with an exacerbation, and it has so many advantages. It is easy to use, it does not need electricity, and the response is very quickly. Many times I've seen nebulizers that run on and on and on, and as we'll see later, you always have a target in which to deliver this salbutamol within a given period of time. So inhaled short-acting beta agonists, either nebulizer or pressurized metered dose inhaler, and the preferred route is the pressurized metered dose inhaler with a spacer to ensure that the child gets the salbutamol into the lungs so that the salbutamol is not ending into the mouth. Otherwise, they will never get out of the tap. Because there is an inflammatory response, like I said, it's an acute or subacute, there is always an inflammatory response, much more than the underlying one that is always going on. And the way to treat this inflammatory response is by the use of corticosteroids. I want again to emphasize the oral route is preferred unless the child is not unable to take orally. Otherwise, there is no reason looking for a cannula, looking for a vein, looking for hydrocortisone. It takes a longer time to help this child as opposed when you have prednisolone, which is actually very cheap, and you give the child. So the oral route is the preferred route. If the child needs oxygen, please give the child oxygen. So I'll now go into the details of how we give this treatment. I mentioned we give inhaled SABA, and I want to emphasize again, it's our first line of therapy, the salbutamol. And so how do we give it? If you're giving it as in a nebulizer or a metered dose inhaler, whatever route you want to use, give 3 doses, 15 to 20 minutes apart. In other words, your aim is that by the end of the first hour of initiating treatment, your child has got 3 doses. And this is very important because if you don't target to have these 3 doses in the first 1 hour, the child will not get out of the exacerbation. Many times we have nebulizers running for 30 minutes, or we are in acute care setting, we prescribe, even the medicine gets finished, but the nebulizer is running, and by the time the person goes to check on that child again, it's an hour down the road, and you're saying that the salbutamol is not working. It's just because you've not optimized the dosing, which is supposed to be 3 doses in the first 1 hour. If you're using the metered dose inhaler with a spacer, you give 4 to 10 puffs, usually according to severity. Again, I'll not give the details of if it's mild, give 4, if it is severe, give 10, if they're 8 years, give 6, if they're 17 years, give 10. These details can easily be got from the guidelines that we have. But I just wanted to emphasize that you can use a nebulizer, you can use a metered dose inhaler. Again, the metered dose inhaler with a spacer is the preferred route, except for children with life-threatening asthma. So these are the spacers you can use. Many times you've heard people saying, but the spacers are expensive. We don't have any in our health facilities. We can actually make these spacers in our health facilities. What you see are things we have in our setting, the things that are causing pollution in our environment, that are causing the waste being all over the place. So you can use a mineral water bottle to make a spacer. Unfortunately, we are online, but maybe if you go on to download to YouTube, you'll be able to download a video and see how you can actually make this a spacer out of a mineral water bottle and how you can use it. But what you're seeing in those photographs is that that inhaler is inserted into that spacer, whatever type of spacer you have. And then you can use either a mouthpiece or a mask. So for younger children, usually less than 6 years, it's better you use a mask, the spacer with a mask. So you cover both the nose and the mouth, and the child breathes in normally. You don't have to instruct them to take deep breaths. After all, when they're having an exacerbation, those instructions are very difficult to follow. So The use of that spacer is that once you puff into that chamber, as the child breathes in, every time they take a breath, they take along the inhaler with them, the salbutamol with them into the lungs, and then it does what we want it to do. You can use, if you're in a health facility, you don't have the bottle spacer, you don't have anything, you can even use these plastic cups that are common, these disposables. When we're at parties, we use them a lot. Just create a hole underneath, use the opposite side as the mask, covering both the mouth and the nose, and the child is puffed into it, and the child is able to receive the inhaled medicines. But of course, as it were, the recommended one is the scientifically designed one. But if you don't have that, please, you can use local material to be able to help that child in your facility. The steroids. Give the steroids, give them early, and if you give them early, it helps reduce the progression of the severity because it curtails the inflammation. Onset of action is the same for both the oral and IV route, usually 3 to 4 hours. So please, again, you don't have to look for the IV route unless the child cannot take orally. Use what is available, give the child, and this one you can even give in between the inhaled medication, other than looking for the medication, rather the IV line, and the child is getting distressed, and then you're looking for the nebulizer, then the child is very distressed, kicks the nebulizing solution and it powers, and the mother has bought it, and all those problems. So you can go around the easy way, but very effective, of using the oral route of the steroids. And we have evidence around this. You may be able to download those publications and read, but at least it has been proven that the oral route is as good as the IV route. And when you're giving these steroids, we shall see the dose later. That's usually a big challenge for many people. But what I want to emphasize that you should give them for a duration of 3 to 5 days only. Never go beyond that period for the children. So the choice of steroids, commonly we have prednisone in our setting, the oral route. So here is where we deal with the dosing. Many times you see children getting 5 milligrams, 1 tablet. They get 2 tablets once a day, or 5 milligrams TDS. The right dose should be 1 to 2 milligrams per kilogram per day. So it is important that you weigh your child, calculate the dose of prednisone they need, and you give preferred once a day. But for children, if a child, for example, is weighing 30 kilograms and you want to give the 2 milligram, you will not go up to 60 milligrams. The maximum you can ever give in a child is 40 milligrams per day, like I mentioned, for 3 to 5 days. And once you do this, there is no need for tapering it down. If you choose to give hydrocortisone for one reason or the other, the prednisone may not be available, and the only thing you have is hydrocortisone, you've got IV access, you give it 5 milligrams every 6 hours. But I would quickly recommend that you change to the oral route as soon as you're able to get the oral medication. Other options are methylprednisolone, not commonly used. We can also use IV dexamethasone in those doses, which you can find out later. So that is what we call the initial treatment. You've given your nebulized or the inhaled medication, you've given the 3 doses, you've been able to give the child the steroid. Please go back and assess the response. It is not the way we used to do, where you admit the child and then you wait 12 hours later to do maybe the post-admission round. You'll have lost a lot of time. So for children with asthma, after the 1 hour, please endeavor to reassess, because it's going to give you on the next course of action. And when you're reassessing, you are asking yourself a question: has there been a good response, or the response is suboptimal, or it is poor? Is the child worsening? You need to ask yourself those questions and be able to take the right direction. And so some of the things we are looking at are the things that we used to assess earlier. Is the child now tachypnic? Is the child still wheezing? Are there retractions? Can this child feed now? How is the peak expiratory flow rate? So the same things we used for assessing are similar to what we assess when we are determining the response to the medication. So If the response is good, move on to what the algorithm says. In other words, there is no more wheezing, the child is okay, then you will continue with the inhaled salbutamol for at least 3 days. The details can be found in the guidance, but basically we recommend that after the first 3 doses, if there is good response, that is not the end of the business. We recommend that you continue with the inhaled salbutamol at least for 3 days. You can give it 6 hourly or at least 8 hourly. It's not uncommon for the child to come in the morning, manage the exacerbation, but then they come back in the evening just because you stopped the treatment prematurely. For the steroids, it's obvious, give 3 to 5 days, no need to taper down. If the response is not sufficient with the inhaled salbutamol alone, you add pratropium bromide. These days, there are medicines that are a combination of both, again, using the inhaled route. So in this case, what we have is what we nebulize. So you have that combination of salbutamol and pratropium bromide, nebulize. Those are the doses. Give every 20 minutes for about 1 to 2 hours, and then 4 to 6 hourly. But what I want to recommend, as you give these medications, always assess the response to treatment, because if you wait for a long time, the child may move from mild to moderate to severe to life-threatening in your own facility. And yet you could have taken appropriate action much earlier when the child is not improving. If you don't have pratropium bromide, you can use atropine. Many theaters have atropine. It is still nebulized solution in those doses. The other medications we use in severe cases, usually in hospital settings, preferably with ICU so that you're able to monitor, but alternatives include magnesium sulfate. I know magnesium sulfate is mainly known as an obstetric drug, but it is very, very helpful in managing asthma exacerbations that are not responding to the conventional medicine of salbutamol or the combination of salbutamol and pratropium bromide. You could use IV salbutamol, not a common drug in our setting, by infusion, or IV aminophylline. In pediatrics, IV aminophylline is our last resort, preferably if you're able to monitor the heart rate, you're able to monitor other parameters, because it has a very narrow therapeutic index with severe side effects. So if you don't have magnesium sulfate, you don't have salbutamol, you've determined the child needs these medications, you can do IV aminophylline, but please, if you're able, monitor the vitals. If you're in a setting that is very good, monitor the levels of aminophylline in the child. I want to emphasize that antibiotics commonly given are not always necessary in these children, because it's only about 19% of children that usually have bacterial infection and therefore require antibiotics. Ensure the child is well hydrated, and now start planning the discharge of this child and follow-up care. So it is important that once you stabilize the child, do a reassessment and determine, does this child need what one would call chronic care, or what we call controllers, as we shall learn later. In other words, do they need to start inhaled corticosteroids or not? When should I follow them up? We usually recommend 1 to 2 weeks. And the reason I want to emphasize this, these children have been under our care in and out, but they are not on maintenance treatment because we've missed an opportunity when we see them during an exacerbation to initiate maintenance care. So part of discharge planning is to find out whether they need this, and you actually start it. And this is my own recommendation. These things that I've described today are from the Global Initiative for Asthma Guidelines 2020, readily available. Google, download, use them as a reference. They're really a very important resource. I'm back to this case of a 3-year-old, cough for 2 days, difficulty in breathing, index squeeze, fast breathing, chest indrawing. They had bilateral wheeze, given nebulized once, rather 8 hourly for 2 days, given hydrocortisone, IV ceftriaxone, and syrup aspirin. I would be very much interested, having gone what we've gone through, if there is anything you think you would have done differently if you are this clinician. I would like to end here and get back to the moderator. Thank you so much for listening to me.